needs to know this.
So, good morning everyone. My name is Senator O'Connell. I'm Professor Cahill's intern, and he's asked me to bring this study to your attention to give you a brief synopsis of what is a provocative paper based on a propensity score matched cohort analysis carried out by Professor Renahan and Associates in the Greater Manchester area of the UK. So this study aimed to address the shortage of evidence regarding the safety of a watch and wait approach, and it did so by comparing oncological outcomes between patients managed by watch and wait who achieved a clinical complete response to chemoradiotherapy and those who had surgical resection of their tumours, currently considered to be standard care. So ONCORE was the catchier title for those who had complete response from chemoradiotherapy, and they were offered a more intense follow-up consisting of outpatient DREs, MRIs every 4 to 6 months, EUAs, CT taps and CEAs. What was compared then was disease-free survival as the primary endpoint, and of note this is the first time colostomy-free survival has been compared between the watch and wait and standard care paths, so this formed a secondary endpoint. So moving on then and looking briefly at their methods, here are the patient clinical and demographic characteristics, and if you look at the breakdown you can see that the numbers aren't huge, but the sample base is very similar to our own and with comparable clinical facilities. If you do read the paper, you'll see they extensively categorise the participants right down to perceived wealth based on address, and it gives more applicable information than the infamous Angelita Habergaman studies that have been performed in Brazil. Moving on to the results then, we see the primary and secondary endpoints portrayed in Kaplan-Meier graphs. Mine don't project so well, but the blue portrays the watch and wait approach, and the purple there portrays surgical response. It clearly shows merit in the watch and wait approach, even surpassing the outcomes of the current standard care. So the question this paper really poses, therefore, is whether this is enough to influence clinical practice. And I'll lead you on to their concluding remark, which suggests that it is. So we think it's a paper worth reading, and they concluded that a substantial proportion of patients with rectal cancer managed by watch and wait, 1, avoided major surgery, and 2, averted permanent colostomy without loss of oncological safety at 3 years. So these findings should inform decision making at the outset of chemoradiotherapy, they found.
At the outset, so 20% of people have a complete response, and maybe we can watch and wait with them. The paper also showed that regrowth within 3 years didn't mitigate against towards a bad outcome. So I asked Jeff.
I was going to talk very briefly just about the complete clinical response to rectal cancer, which is one, I think, now of the hot topics in colorectal surgery, and as a colorectal surgical trainee I'm very interested in it. Obviously before now the main standard of treatment was to do surgery, obviously with or without neoadjuvant chemoradiotherapy in the form of either anterior resection with or without defunctioning ileostomy or an APR. Surgery though isn't without complications. People can have a permanent ileostomy, an anastomotic leak, an anastomotic stricture, functional disorders, as well as a mortality rate of up to 5% in the perioperative period. So the question is now has been raised, particularly in the last 20 years following Angelita Habergaman's study from Brazil and some subsequent papers. What do you do with a patient when you look in after having neoadjuvant chemoradiotherapy and they have this nice healthy scar at the base here, no evidence of any disease within this area, and the MRI scan is again suggesting there's no evidence of disease? Do you put them through an operation which might potentially show no tumour whatsoever, or do you leave them and watch them and wait? So there have been a number of papers published in the last 20 years, first of all by Angelita Habergaman, a further one by James Smith, multiple observation studies which again have shown that people can be watched clinically without having to have surgery with regards to this treatment, following one which is done by this most recent paper. Obviously there are other caveats to this. There are some papers which would say that people can't predict clinical response, and there's quite a high proportion of patients who will have residual disease despite having what is perceived as a complete clinical response. There are also papers which would show that even a luminal response, people will still have a small number of people will have positive lymph nodes and therefore will have resistant disease, present disease. So I think from my point of view, it's very interesting because we've got these two separate areas which are really dividing the community. We know that up to 1/5 of patients will have a complete pathological response seen on a resection specimen after neoadjuvant treatment. And obviously these patients have undergone a significant surgical procedure with potential significant complications, potentially unnecessarily. There have been an increasing number of studies which have suggested that we can watch these patients quite closely, obviously, with MRI and endoscopic observation. The rate, how often, we don't know yet, but that these patients don't or aren't at a worse potential outcome than patients who have full surgery. And if they do have regrowth, they can be salvaged with surgery without any significant complications. Do we need to have an RCT to actually to confirm this? Possibly. And then the question is then, currently with our management practice today, when patients come in after having neoadjuvant chemotherapy and they have a complete response, should we be discussing the option of watch and wait with these patients, knowing that yes, they might recur, but also they might not, and we can then forego a significant surgery, which to me is all very interesting.